Thank you for joining us for this session, What's New in Cervical Cancer? We're joined today by Dr. Nita Lee, an Associate Professor of Obstetrics and Gynecology at University of Chicago Medicine. Dr. Lee's interests include cancer survivorship, cancer disparities, and clinical trials focusing on new therapies for ovarian, uterine, and cervical cancers. She's also interested in the screening, prevention, and early detection of gynecologic cancers by educating providers and patients. Thank you for joining us, Dr. Lee.
My name is Nita Lee, and I'm here to discuss updates and treatments for cervical cancer. My disclosures, I have a few, mostly for educational purposes from the National Ovarian Cancer Coalition for educational consulting support and PCORI funding for partnership with Research in Alliance. My goals today are to really sort of give a little bit of an overview. I want to level set so that everyone can kind of have the same approach when we're thinking about treatments for cervical cancer. Just a very brief overview of cervical cancer staging, some discussion about options in surgery for early cervical cancer, including approaches, a brief review of chemoradiation for locally advanced cervical cancer, and a lot of time spent on some of the new therapeutic choices that are available for recurrent cervical cancer or disease that has distant involvement. And that includes immunotherapy, some targeted therapy, and some focus on clinical trials. Just to kind of back up a little bit, staging of cancer is often the first thing we think about when we are diagnosing a patient with a cancer. And it's the first thing that I get asked as a GYN oncologist, like, what stage am I? What do I need to know? And this is really important because this is where the cancer is located at the initial diagnosis. It includes the size, the location, whether or not there are lymph nodes involved. And it's important to know that the stage does not change if you get a recurrence of your cancer. It still remains the same. We just talk about it differently. When we think about very early cervical cancer that can be treated surgically, we are often talking about scale of really in the millimeters. If you look at this reference point, 1 to 5 millimeters in terms of how small these areas are, a very early cervical cancer can only be seen microscopically, and it may only be as large as 3 or 5 millimeters. And that helps us determine some of these finer staging. If the tumor is larger and limited to the cervix and up to about 2 centimeters, it may be able to be seen visibly, but again, it's still small and something that we're actually diagnosing with the help of our pathologist. Again, one of the other things that staging helps us decide by determining the size of the tumor is to really see, is this an option for us to do surgery? So in general, for tumors that are less than 4 centimeters, that's actually where we think a surgery, whether it's a radical hysterectomy or some type of fertility sparing surgery, may be an option. However, for tumors that are greater than 4 centimeters or involved tissue outside of the cervix, then in that circumstance, we often have other treatment choices such as chemotherapy combined with radiation. So again, size and staging helps us decide if surgery is an option. When we think about surgery for early stage tumors, which are less than 4 centimeters, we're often thinking about some type of hysterectomy, which is the removal of the tubes as well as the uterus and the cervix and some of the side tissue. This picture doesn't completely tell the whole story because oftentimes we preserve the ovaries and do not remove the ovaries, but this is just so that you can get a visual. We often preserve the ovaries in patients with cervical cancer because cervical cancer in general is not something that is estrogen dependent or hormone driven, and that we actually have options for being able to not have patients go through early menopause. There are different methods for being able to do the surgery in terms of a low transverse incision or a vertical incision. In very, very early stage cancers, we may even be able to do something that is cervix limited, such as a cone in a microscopic cancer, where it's just a removal of a portion of the cervix, or something called a radical trachelectomy and lymph node dissection, where the entire cervix is removed. This is limited to patients who have tumors that are less than 2 centimeters and have no other adverse features on pathology. We also want to make sure that patients who are thinking about fertility sparing are appropriate fertility candidates and may have had consultations with reproductive endocrinology and infertility to gauge their fertility prospects. Clinical trials are really important because they can actually help us change practice. So here are some surgery-focused clinical trials that have helped us change practice. Previously, when minimally invasive surgery was adopted, this was adopted for cervical cancer as well, and a randomized trial looking at the role of minimally invasive radical hysterectomy was performed using open versus invasive, minimally invasive surgery. In this study, surprising to everyone, minimally invasive radical hysterectomy was associated with lower rates of survival and overall survival compared with open radical hysterectomy. This really became practice changing in how we approached this and how we counseled patients about the type of approach that we could do surgically. There still exists controversies, ongoing new trials looking at whether or not this can be changed based on the size, the approach, and the experience of the practitioner. So this is obviously a consultation, a conversation that you would have in consultation, but it is important to know what some of the background is. For example, another trial called CONSERVE was a prospective trial looking to see if we could actually minimize the amount of surgery that we could do for low-risk early-stage cervical cancer. So instead of the radical hysterectomy, which has a little more effect and side effects for the bladder and bowel function, as well as sexual function, this study was looking at the rate of being able to do a simple hysterectomy, which is a less morbid procedure. And this actually showed that conservative surgery was similar compared to historical rates of how people did with the radical hysterectomy, and did emphasize the need for lymph node assessment in this even low risk population. Again, this hasn't completely changed our practice, but it is important to kind of think about how we think about clinical trials and how important they are in terms of helping us decide what the best options will be. In patients, many of whom I see, they are diagnosed with something called locally advanced cervical cancer. And that means that the cancer has advanced beyond the cervix or is of a certain size. As you can see here, stage 2A, 1, and 2 cancers may involve both the cervix and extend into the vaginal canal. Stage 2B cancers extend into what's called the perimetria or the side tissue. And stage 3A cancers refer going down towards the lower part of the vagina. Stage 3B can involve the ureters, which is the tubes that go from the kidney to the bladder and cause kidney dysfunction as well as more pain. And stage 3C actually involves the lymph nodes, which is often found on some type of imaging, either MRI or PET-CT. So for these patients, chemoradiation is really the standard of care in the United States. This may differ in other countries, and it may differ based on what sort of modalities are available. But in the US, we generally will treat this with a combination of chemotherapy and radiation. Chemotherapy and radiation is given jointly in this setting. This is a weekly chemotherapy, which is most often cisplatin, but can be other drugs depending on the person's renal status and other issues. This is given in a timely weekly fashion, while the external outside radiation is given daily over usually a 5 to 6 week period. Brachytherapy or internal radiation is a very critical component of chemoradiation, and we really cannot achieve cure without having that brachytherapy component. In addition, not receiving brachytherapy is a marker for maybe not receiving some of the standardized care, and there are disparities in who gets brachytherapy, both in terms of race, ethnicity, and rural versus urban settings. With this backbone of chemoradiation, newer studies are looking at the addition of immunotherapy that are upfront with radiation and chemotherapy. I'll be talking a little bit about immunotherapy next, but keep that in mind that we are trying to move some of these newer treatments into the upfront settings. So just to kind of back up a little bit, there's a lot of terminology that I think is really important to kind of get out there. So one of the things is the idea of chemotherapy versus targeted therapy. So chemotherapy is DNA damaging by design, and it is actually designed to be able to kill cancer cells when the DNA is actually affected and the DNA is somewhat corrupted. This damages normal cells too, which leads to the side effects. Common side effects related to chemotherapy and radiation include fatigue, hair loss. In general, with chemotherapy related and given as a low dose with radiation, most patients don't experience significant hair loss. This can cause nausea and vomiting or GI disturbances, a loss of appetite, diarrhea, other issues. And so this is really important to kind of think about how we think about the side effect profile and the quality of life of any of our patients who are undergoing treatment. Targeted therapy is a really broad terminology, and this usually refers to a set of drugs that are called monoclonal antibodies, and that's abbreviated here. These are engineered molecules that are supposed to target a specific receptor or protein that lives on the cancer cell, but not on normal cells, hopefully, therefore, creating less side effects to other normal functions in your body. And I think that's a little bit difficult because we know that all of these treatments will have side effects, but they may be different. And our goal is to really develop therapies that are more targeted and less broadly affecting all parts of the other organ systems. This is kind of along the lines of something that you may have heard of, which is called personalized medicine or tailored treatment. So, in general, one size fits all, everybody gets the same chemotherapy. Some people will have an effect, some people will have no effect, and some people will have more adverse effects. Medicine of the future, or this that's happening now, is the use of using biomarkers such as tissue or tumor testing to help design better therapies. And I think of the targeted therapies are generally usually in this category because the biomarkers are what helps the scientists who are discovering these molecules figure out which target they want to hit. And so thinking about that helps us to kind of think about how these are fine-tuned. So just as an example, this shows if there's a cancer cell and there's these various proteins on the cell, this is how a designed monoclonal antibody can actually affect these proteins. These proteins sometimes have downstream effects in the nucleus or the center of the cell as well. And so this is kind of some of a simplified mechanism of how some of these work. So some of these antibodies are not really as specific and they target generalized things, such as, for example, bevacizumab, which is a VEGF target, doesn't really intentionally target the immune system, and we'll talk about that in a bit, or pembrolizumab, which targets immune-mediated immune suppression. Bevacizumab is a drug that has been established to have activity in cervical cancer. It is a drug that was first established to inhibit angiogenesis or new blood vessel growth. This is a monoclonal antibody that inhibits angiogenesis by binding and neutralizing to a compound called VEGF. Tumors secrete VEGF to help promote building their own blood vessels to, again, get more nutrients and continue to grow. Bevacizumab blocks this and allows the tumors to have a more normal growth pattern, allow chemotherapy to get to this, and prevents overgrowth of blood vessels. This is a simplified schematic, actually from a neuroradiology journal, as this drug is used for many different types of cancers. Since 2014, bevacizumab was added to the chemotherapy backbone and showed improvement in survival for patients with recurrent metastatic cervical cancer. Just a figure of showing what the original study demonstrated. This was looking at the idea of chemotherapy alone, and here are some of the drugs that were used. Paclitaxel, cisplatin, with or without the bevacizumab, paclitaxel topotecan, with or without the bevacizumab. And this was really important because before this, we really had limited drugs that were available that were in the targeted range. And this was a really important step for patients with cervical cancer. We saw that the addition of bevacizumab to chemotherapy showed an increase in overall survival. Unfortunately, it was still modest, with 17 months in the patients who had bevacizumab versus 13 months. It also showed a higher response rate. However, there were concerns regarding hypertension, blood clot events, and fistulas, which can adversely affect quality of life. Hypertension can be generally very well controlled, but again, the fistula formation and other risks made us really want to think about the balance of the benefit and quality of life concerns and really tailor the use of this drug for patients who may be a little bit at less risk for fistula formation, or at least counsel patients about the benefits and risks of these new drugs. So immunotherapy is another way of treating the cancer. Immunotherapy uses the body's own immune system to fight cancer, and there's several types of immunotherapy. This Cancer Council from Australia actually has a wonderful guide for immunotherapy, and so I would recommend if anyone's interested, that's another resource. Checkpoint inhibitors, some may have heard of the word pembrolizumab, this is a common one that is used for cervical cancer. Remove the barriers that stop the immune system from finding and attacking the cancers. And again, we'll go over some of these different types again. The pembrolizumab is a checkpoint inhibitor. This drug binds to a receptor or a protein on the tumor cell, the PD-1 receptor, blocking the immune suppressing proteins. These immune suppressing proteins is how the tumor cell is actually able to avoid the T cells, which are the body's immune fighters, and the way that otherwise cancer cells could be killed. So in 2018, PD-L1 inhibitor Pembro was approved by the FDA for recurrent cervical cancer. The original trial demonstrated an overall response rate of 14%, which was higher, unfortunately, than many of the other drugs and had a better side effect profile. This was specifically done for patients whose tumors were tested and had a PD-L1 score positive. This introduces the idea of biomarker testing. For example, testing for this protein on the surface of the tumor helps to classify the tumors, and this is a pathology test that can be run on anyone who has a recurrent cancer or even a new cancer to help decide if immunotherapy in the future could be an option for them. So understanding that it is not just the pathology, the cell type, but now we're going into these different levels of biomarker testing is really important because we really want patients to advocate for themselves to ask, what is my biomarker testing? Has my tumor been tested? And so this is a really perfect example of it. Other immunotherapy trials in cervical cancer also showed benefit similarly, which was better than chemotherapy standard choices. So this trial was a phase 3 trial that looked at another chemotherapy checkpoint inhibitor and looked at that versus the chemotherapy chosen by their physicians, which they would have been on otherwise. And overall survival was noted to be better in the immunotherapy arm. Keynote 826 was another study. It was a randomized double-blind phase 3 study, which was looking at now adding Pembro, the immunotherapy, to the backbone of chemotherapy with Avastin or bevacizumab. And I think that's really important to kind of think about. This was sort of a trial that was looking at if adding this improved overall and benefit to the patients. And in this study, we did see a demonstrated benefit for patients who had the pembrolizumab added to their backbone of chemotherapy and bevacizumab. The really important thing about a study like this is, though, we don't know if there's any data as to whether or not the benefit it would be just as much if we were to actually stagger these drugs. And so there's a lot of study being done on like sort of the sequencing of these drugs as well. But the addition of chemotherapy with bevacizumab and pembrolizumab is a discussion that we should be having. There are some ways clinically that this discussion has to be made, and a lot of it has to do with the disease sites as well as the risks that an individual may have with either the Pembro or the bevacizumab to see if we can safely give both. So immunotherapy, again, remains complicated. We talked a little bit about immune checkpoint inhibitors. There are some therapeutic vaccines, which are investigational, and there's something called adoptive cellular therapy, which are different technologies. Tumor-infiltrating lymphocytes is one method that I will review very briefly. Again, this is an introduction just to sort of familiarize yourself with some of the terminology and the importance of being able to really explore some of these options with your physicians or even advocate for learning more about what may be available at your center. So tumor-infiltrating lymphocytes takes tumors and resects them and isolates the tumor-infiltrating lymphocytes, which means these are the white blood cells that are within the tumor, which may actually be able to respond and kill the tumor. These are expanded in the lab and then given back to the same patient after giving them some initial chemotherapy to get rid of some of their other T cells. So an original abstract in 2019 demonstrated a response rate of 44% and a complete response rate of 11%. Currently, this is really only available in clinical trials at the present time, but it is really important as it uses a very different mechanism other than immunotherapy or the traditional checkpoint inhibitor immunotherapy. So this is the one, the LN-145 Iovance is the trials or the mechanism that is now FDA approved to be studied still in study in clinical trials. So a tumor is resected. There must be at least 2 centimeters of tumor and sent to the lab. The TILs are identified and genetically modified and amplified to billions within 3 or 4 weeks. The patient receives chemotherapy to prevent the rejection of the infused T cells, and this TIL army is reinfused. And so I think this is, the confirmatory studies are in progress, and that's where we are right now in terms of enrolling patients on TILs trials. Another drug that is really important and a mechanism that we want to kind of think about is something called ADC. I'm going to go back and forth. Antibody drug conjugates. So this means that there's a monoclonal antibody that's linked to something called a payload or the actual active ingredient. Now, since 2014, there have been 14 of these types of antibody drug conjugates that are approved by the FDA and 2 for gynecological cancers. So the monoclonal antibody binds to the target receptor, the entire compound with the payload, which is kind of like this sort of the secret linkage, is brought into the cancer cell. The membrane around the payload dissolves, and the payload can find the DNA and destroy that individual cell. And I'll go back to kind of show how this is supposed to be. So if you look at this ADC binds to the specific protein. It is sucked into the cell, and eventually the payload, which is these little yellow drug-related symbols here, is able to go into the nucleus and disrupt the DNA. So there are a lot of different types of payload or drugs that are linked, and there's a lot of different types of these actual like monoclonal antibodies that can be used. And so this is really important because this has really become another mechanism that we don't often talk about that's very different than chemotherapy. So currently, cervical cancer has one of these such drugs, tistozumab, Tivdak, tissue factor, which targets the ADC, and the tissue factor is the targeting monoclonal antibody, and then the drug is able to kind of enter. This was given accelerated activity in May of 2021. It does have side effects, including traditional side effects such as affecting bone marrow and affecting neuropathy, but it has an important side effect of significant eye toxicity. So this has to be managed very carefully with your physician and your nursing team, as well as all of our patients seeing ophthalmology for really preventive eye drops and eye gels. It's a very unusual side effect. And that's what we have to kind of keep in mind, is that we're sort of balancing a lot of the newer drugs that are happening alongside the ability for us to kind of manage newer side effects that we may be seeing. So again, this has a press release that had a confirmatory trial, and we will be seeing this publication pending. Thank you very much for your attention today. We want to be able to kind of give you a hint of all of the different types of new treatments that are available in cervical cancer so that you are able to gauge how you can best talk to your own physician and your treatment teams about best options for you. Thank you.